in the or right now, you just heard a very nice woman from Zoom let you know that this is being recorded. So just so that everybody is aware, please don't be shy about speaking up, asking questions. This is just recorded so that we can share it with those that couldn't make it during the 12 to 1 o'clock hour. It is not the perfect time for every practice, but does seem to work for the time being. So with that, I do want to kick it off with a quick poll. So I'm launching the poll right now. I just want to know if you've been to town hall before or if this is the first time that you're here. So go ahead and answer that question that popped up on your screen, and I will give it a few minutes for everybody to answer. You guys are quick. We're already at 92%. Give it a couple more seconds in case there's any stragglers, and then I'll close it out. All right, so you should see the results on your screen. Looks like we have a good mix, about 70% that were here last time and 30% or 7 people that have not been here before. So thank you all for coming. Hope that you find it helpful. We're certainly excited to have you here, and we do have a busy agenda today, so lots of good stuff to go over. I'm going to talk about some medication reconciliation updates very briefly. We will go through some details around the 21st Century Cures Act. Rebecca Cooper-Piela, our Chief Quality Officer, has joined us to talk about a tobacco cessation initiative, and Jared will give us an epic demo for the clinical staff workflow there. And Lisa Stemska also joined us very graciously to help give a little rundown of how to use the Galen legacy system, as well as answer any other epic questions. And then we'll get an update on the Ambulatory Practice Council and some employee recognition updates as well. So with that, just a brief update about medication reconciliation. None of this is new information within the last couple of weeks, but I did just want to review it here because we talked about this at our last town hall. So what you see on your screen now is a clarification email that went out with kind of additional guidance around our med reconciliation policy, where we are saying that it is okay for clinical staff to remove duplicate medications after confirming it's a true duplicate in dose, route, and frequency. That you may remove over-the-counter medications and that you may remove expired medications. You also may add medications to the list as patient reported. That was not new, but we just wanted to reinforce that piece. The goal in making those changes, just so that everybody understands, was based on feedback from providers and clinical staff alike, along with us really looking at workflows and spending some time one-on-one with some people in the practices to see what was working well and what was not. So we hope that things are going a little bit smoother for everybody in that realm. And if they're not, certainly keep your feedback coming. Feel free to ask questions. It's a very important topic. Now to jump into the 21st Century Cures Act. So I'm not sure if people have heard about this at all, or some people may be more knowledgeable about it, but we're going to do a brief overview, and there's going to be more education that's coming for you all. So to start, what is the Cures Act? It's a federal law that outlines how healthcare providers and health systems should be sharing patients' electronic health information. The goals are to provide the patient with real-time access through tools such as MyChart and allow them to be more engaged advocates in their care, as well as protect them from information blocking, meaning blocking access to their electronic PHI. Some of the basics, it's about putting the patient first in healthcare technology, increasing their access and making sure that they have access to their information in a timely fashion to make an environment where the patient is truly part of the care team. It also provides process and policies that block a patient's access to PHI that are not allowed. There are some exceptions to that where, as an organization, we can hold some information back, but those are few and far between and are in very specific circumstances. So what is information blocking? It's when you prevent or discourage a patient's ability to access or exchange or use their electronic PHI. There are a few exceptions that fall into a couple of categories. So there's a preventing harm exception and a privacy exception that we're going to briefly talk about. So preventing harm would be when there's concern of physical harm to a patient or another person by giving them the information, or you're documenting a mental health or potential minor or elder abuse situation that should not be shared with somebody else who has access to their record. So it would not be information blocking if we're denying or blocking a parent's access to notes in a minor child's records that outline suspected abuse. What could be considered information blocking, though, would be not releasing results that indicate cancer prior to a provider conversation with the patient. So this will end up being a challenge in those situations, because if we all know that if a provider orders something on a Thursday or a Friday, the patient goes to have that test, or we have pathology results from a biopsy come through on a Friday afternoon, those results are now eventually going to immediately be released to the patient, and the patient may see that before the provider sees it and before they can have a conversation with them. So this will change the conversations that we need to have with patients in kind of giving them that anticipatory guidance that you may see these results before we do, and that we will reach out to you as soon as we can to have a discussion. And patients can then choose, no, I really don't want to see those results before you do. There'll be a lot more information coming about what that looks like in the medical record and how you all can help to make sure that patients get their information in a timely fashion, and those that don't want it to come to them first won't get it. The other exception that does impact us in New Hampshire, specifically around the privacy exception, would be HIV results. So there is state legislation that a provider has to have a conversation and counseling with the patient when sharing HIV results. So that is an example of something that would not be immediately released to the patient. For you all as clinical staff who are documenting in the chart, some general documentation guidelines. Before we go through these, the thing I would want to emphasize is that patients have always had access to their full medical record. This is about when and how they have access. So we should always be thinking about these things when we're documenting anyway. Patients can and have the right to request a copy of their medical record in its entirety. Now they will be able to see more of that information immediately in my chart. So documentation should always be objective and factual. You need to document the patient's perspective, use quotes when applicable, use descriptions instead of judgmental or labeling language. Be mindful of the tone in your note. When unsure, mirror the way you would speak directly to that patient. Highlight the patient's achievements along with their health problems. Use language that's positive and supportive. And continue to fully document the patient's condition. Patients will research terms that they don't understand, and it's important that we continue to clinically document everything that's appropriate. Some additional documentation guidelines and words of caution. So try not to blame or point fingers at other healthcare providers. Don't surprise the patient with information that you haven't discussed with them. Avoid speculation, avoid the overuse of abbreviations. And be mindful of the use of jargon and acronyms. A quick crosswalk with some terms that we commonly use when we're talking about patients and patients' care, and then some alternatives to that language. So when we say someone's a poor historian, it would be better to say patient could not recall. Instead of saying a patient's non-compliant, we can say that they chose not to do something. Instead of the word refuse, using declines. So it's just thinking about your language, again, so that it's coming more from an objective and factual place of respect, rather than using some terms that a patient may interpret as more inflammatory or derogatory. So what does this look like in terms of timeline? So in the ambulatory world, a lot of our documentation from the provider standpoint was already being shared and was available to patients in the portal. So some of the bigger changes that are going into place as of July 6th, you can see there that there's more release. Again, the ambulatory notes were already available, you can see, but there's now going to be automated release of inpatient notes unless there's an exception that applies. There will be sensitive notes that will just be manual release. That'll be more in the behavioral health space. And pathology results will continue to be manual release only. As we work towards the end of the year, though, so in the October timeframe, we're working towards more things being automatically released. And there will be subsequent education coming out from the health system about what that means and what it looks like. The other couple of things that I wanted to put in here, this is just a snapshot of some frequently asked questions from the Solution Health website. So will notes be shared? Yes, beginning on July 6th, they will. However, telephone encounters will not be shared starting on July 6th. That will come later in the year. From a nursing and clinical staff perspective, some of the questions and concerns that people have brought up were patients being able to access their full name. My understanding from the answer to this question, and I will say that we're still having conversations and seeking some clarification on some of these things, is that if the note is written by somebody who the patient can't schedule an appointment with, then it's just going to show that author's first name and last initial with their credentials. Full names and credentials have been viewable to patients in other areas for quite a while, though. So just something to be aware of. And again, they can request a full copy of their medical record where it would say your name on the paperwork that they are requesting. Additional resources that will be available. So there's a health stream module that's coming out likely next week. It's just being finalized and assigned. There are some EPIC modifications that are being made and tip sheets that will be coming out to staff as well. Just a couple of hours ago, we got an all staff email from Solution Health that had some more information as well as links to the Solution Health resource page. And continued support and education through your practice managers, us as a nursing team, quality, and education. So please reach out with any questions, concerns, any support that you need. I will send out these slides after. There is a link here to the Solution Health CARES Act page, which has quite a bit of information. And then you can also contact the CARES Act committee directly. They have an email address that you're welcome to reach out to with any specific questions. We got through that in only 10 minutes. So does anybody have any questions specific to the CARES Act that they would like to bring up now? I do see one question in the chat while people are figuring out if they can get off mute. So can a patient request an addendum to a phone note if they do not agree with the note? Yes, there will be a process where a patient could come forward and ask that something be changed. But just because they request something be changed doesn't necessarily mean that that change will happen. So if there was a comment about one of the recent examples that you can see on the Solution Health page is a patient reaching out and asking that their illicit drug use be removed from a progress note because they didn't want it in there. The clinician can respond and say, well, that drug use is relevant to this current medical condition that we're treating and does need to be documented in your chart for that reason. It's a good question from Anne in the chat as well. Does the term released mean as soon as the result is posted in the chart? My understanding, Anne, is yes. That means as soon as the result is finalized and available for us to see as clinical staff and for the providers to see, that eventually it will also be released to the patient at that same exact time. We will not get to that point with everything until October. So right now, when we are going through that grid, pathology results will still be getting manually released. So the provider will see it first. Victoria asked, are they able to see historical centricity notes? That's a really good question. I don't think they can. They would just see what's in my chart. But again, they could request a copy of that medical record at any time. They would just need to go through our medical records department to get that. That's a good question as well. I can't tell who that is. Somebody with the last name Reynolds, I think. Will notes prior to go live date be available to patients? I actually don't know the answer to that, so I'm happy to find out what that would look like. All right, these have all been really good questions. If anybody thinks of anything while we're continuing on with the agenda, you can certainly bring those up at the end. We did just get one more question in the chat. Does the legacy access allow for us better access without having to go through centricity? So Jen, we're going to talk about the Galen legacy system in a few minutes and talk about that. Jen, we'll talk about your question, I think, a little bit later. So at what point should other provider offices be directed to medical records? I think I'm going to need a little more clarification around what specifically you need, or what you mean rather. But in the interest of time, I am going to have us move on to the tobacco cessation initiative and invite Rebecca to join us.
Good afternoon. Thank you very much for inviting, and it's a pleasure to be here with you. So in our old system in Centricity, many of you may remember where we had some delineation and some of the radial buttons that talked about whether we counseled patients to stop smoking or not smoking. We know that smoking cessation and tobacco cessation is a very important part of patients' health. It impacts many of their other chronic conditions. And this is an initiative that's measured as a quality component to some of our contracts with our payers, and something that we're looking at in our accountable care organization at Solution Health. So that was kind of the foundation of where this work was reinvigorated. We brought together a group, a multidisciplinary group across Solution Health, which included some of our nursing colleagues. We included colleagues from pulmonary rehab. We had some of our providers, including primary care, pulmonary. We had a substantial amount of help from Julie Zakowski, one of our practice managers, who previously worked with the state of New York for the smoking cessation program. And what we have done is we've worked with our colleagues across both systems to develop a workflow that's aligned with best practice clinical standards, and also gives you the tool in Epic that's aligned with that work to provide our patients with smoking cessation resources, whether it be counseling, whether it be a handout, whether it be a referral to the New Hampshire Quit line, which we used to have when we were available in the Centricity program. And so what we're looking to do is reinvigorate that discussion around our patient smoking and some counseling around that. I don't know if we're going to advance slides or.
Yes, sorry, Rebecca.
That's okay. So our goal really isn't to improve the health of the population, which we talked a little bit about, and if we could go forward. And so how do we do this? It is an ACO metric, which I was talking a little bit about, but again, it's something that all our patients benefit from, and it's a part of our regular workflow that we're going to continue to encourage. This is some of the why. When we think about how many Americans smoke, we know we encounter it in clinic on a regular basis, and we look at the money that's spent in terms of healthcare costs and the burden associated with that. Next slide. So who's involved? We talked a little bit about that when I opened up as well. It's our Foundation Medical Partners colleagues and our Elliott practices in our ambulatory setting. We have the Manchester VNA who's involved already, and we hope to bring this system-wide. Next slide. So what's involved? We want to ask every patient at every visit about tobacco use. Patients that are using smokeless tobacco, patients that are using cigarettes, we want to encourage them to quit. We want to find out, are they ready to quit? Are they not ready to quit? What are they sharing with us for information? And we want to introduce a very brief coaching session and arrange a follow-up, and we want to document that. Next slide. So expectations for our clinicians that are rooming. Again, we're going to be asking the brief counseling, document yes or no. And Jared, I think, and Lisa are going to take us through the actual Epic demo, and I want to make sure we leave time for that. I think that's important. We want to do that handoff to the provider. So, you know, if Mrs. Jones is here today and she says to you, you know what, I'm really ready to quit today. I want to talk about a medicine. So we want to let your provider know that patient is in a stage of readiness so that we're going to be ready to ensure we give the patient the resources necessary to move forward. Next slide.
So I think at this point, Rebecca, we're at the Epic demo piece. Thank you very much for giving the overview. Does anybody have any questions for Rebecca about the smoking cessation initiative itself? And then we'll go through the Epic workflow for everyone.
And just one other point is that we did have a CME. We're working to post that on June 8th. And so we'll be sending out some more information once we post that.
Excellent, thank you. All right, Jared, I'm going to hand over the screen to you and stop sharing.
Actually, if you want to put that slide back up, that will be my intro, and then we'll jump into Epic.
Sure.
Okay, so essentially when it comes to your workflow in the clinical setting, this initiative for you as clinical staff is going to start during that rooming process. So the first thing that you want to think about is a simple kind of one-liner. It's a couple lines, so I can't say it's a one-liner, but it's a short little blurb that you can give to patients. Pretty much everybody who is a user of tobacco should hear this message from the clinical staff who are rooming patients, that quitting smoking is the most important thing you can do for your health. We care about your health. We want to help you quit. What are your thoughts about quitting smoking? So having that open-ended question there will hopefully lead the patient into revealing to you where they are at in terms of wanting to quit or not. If they are saying that they're not interested in quitting at all, then it's pretty simple. We can just say, we understand quitting can be difficult. And then we wrap up the conversation with, we'll continue to work with you. We're going to ask you again in the future at some point. And when you're ready to quit, we're here to support you with tools and resources. If the patient does indicate they're thinking about quitting at all, then we can, encourage them. I'm happy to hear you're thinking about it. Would you like some information to review while you wait for the provider? There will be resources coming from various agencies that are going to be in the practices that will be standardized across sites as to what we give patients in terms of there's a handout or a brochure that we can hand them to just look at about some of the resources that are available to them. So it's a simple 3-step process. Everybody who is a user of tobacco hears that brief message that it's the most important thing they can do, that we want to help them. If they indicate that they're thinking about it at all, we give them resources. And then we always leave it open-ended that we're going to continue to work with people wherever they're at in that process. And then that information gets handed off to the provider and documented in the chart. So we let the provider know that we talked to the patient about it, that where they're at in terms of whether they want to quit or not. And then the provider picks it up from there. And they have some additional process that they're going to follow that is in addition to this. So the evidence shows that essentially the more people that patients hear this from, the more effective it is. So if they hear it from you, they hear it from the provider, and they hear it from others in their care, eventually that helps move the patient along. Even if they're at the moment not ready to quit, we can hopefully get them closer. So what do you need to do in Epic? Well, we're going to take a look at that now. So if I can share my screen here, I will show you what this looks like. So in Epic, does everybody see Epic on the screen?
Yes.
Yes.
Awesome. So when you're rooming a patient, you will find the information under vital signs. Most of us are probably asking about tobacco use already. The additional component here is going to be indicating that we have given counseling and then documenting a little blurb about that in the chart. So there's a couple different ways that we've seen people go through this, documenting this process. You could scroll down to the history section and find the tobacco use, but we've found through some experiments that that's actually not the most efficient way. The quickest way is to click this link that says edit tobacco use, because it jumps you immediately to tobacco use. You can go directly there, indicate what the patient's current status is. And then the key thing here is to, when we deliver that one-liner to the patient, we're going to check this counseling given box. And then the other piece is that in your note, in your rooming note, you're going to type .quit. And that basically drops 2 lines into the chart that summarizes that same message. It's also helpful if you forget the wording. It's pretty much the same in that quick text or smart text as what's in the support documents. All of the primary care practices should have received the standard work document that actually outlines the more detailed step-by-step, what to say and if the patient is ready and if they're not. So this isn't obviously as detailed as that, but it will give you some prompt if you forget. So that's the basic process in terms of documenting the smoking status. We do want to make sure that we're documenting how much the patient is smoking and the pack years. Now, what's interesting about the pack years is once you document it the first time, we do not want to go back in and change the packs per day or years, because it actually recalculates. So if the patient started at 1 pack per day and maybe they've reduced down to a half a pack a day, you'll notice that it changed the calculation of pack years, which is not clinically accurate. Pack years is a cumulative calculation. So once you have 30 pack years, You always have 30 pack years because that's your history. So that's a flaw in the EPIC calculation. So instead, once there are numbers in this box, we're not going to change those numbers. We're going to put it in comments as current amount of, say, 1/2 pack per day, which I can't type, so that's not helping me. So if that makes sense, that's what we're asking people to do, is once there are numbers in this box, don't change them, because that will change the calculation. And this number in particular is very important for being able to screen patients for lung cancer who have a history of smoking. So if the pack years number is not accurate, it makes it very difficult to get those screenings approved and make sure patients get that preventive care that they might need if they have a history of smoking. So that is essentially the, oh, and I should show you this too. So once you actually are here, if you don't know how to get back to the rooming tab, it's actually quite simple. You just click the X and it brings you directly back to where you were, which is one of the reasons why using that link is faster, is that once you're in vital signs, if you click on edit tobacco use, it jumps you directly there. And then when you click the X, it brings you directly back. So if you've been scrolling to find the tobacco use and the history, it takes a pretty long time, and it's not the fastest way. And so hopefully that you'll find that helpful in getting there quicker. So that is that. Any questions?
Jared, there are a couple questions in the chat. So first question is, if the patient is not ready to quit, does the discussion stop at the nurse?
No.
Correct. Yeah. Go ahead, Jared, if you want to, Jared or Rebecca, if you'd like to speak to that a little bit more.
Yeah, actually, I think I'll defer to Rebecca on this one.
All right, absolutely. I would have a conversation with the patient as the provider once I receive that handoff, again, encouraging them and reminding them that we're there for resources should they have a change in heart. You know, having done this over time, it's amazing the impact that it has when all of us ask repeatedly. There are many patients that have quit after years, and, you know, they've shared with me that that's in part helped them quit. We know it's evidence-based, but when you hear patients share it, it's very meaningful.
Thank you, Rebecca. The second question that we have is, do MAs have to do this? The answer is yes. Any rooming clinician, so whether it's an MA, an LPN, or an RN that is rooming that patient, the expectation is that we're asking about tobacco use and that we're documenting that conversation appropriately. The next question is, are you working on some sort of warning, pop-up, or sidebar instruction next to the pack years form in EPIC to remind to not change?
As of right now, I don't know of anything. And I think the goal is going to be to work with EPIC to see if we can fix that calculation, because that's the real root of the issue there, is that the calculation is not accurate and shouldn't change.
Thank you for asking that question, Aaron. I think you have a very valid point that anywhere that we can automate that and use EPIC to our advantage, A, to correct the calculation issue, but B, to remind us all that, hey, don't change this number, is definitely important, because otherwise it is hard to remember. So if that's not already in progress, we will kind of bring that up. But I do know that people at the system level were concerned about that as well and are looking at it to make sure that we have accurate calculations.
I would say there's awareness, and we're happy to bring feedback once we have some more clarity there. Excellent question.
Thank you all for your questions and engagement so far. This is great. Really appreciate it. Anything else on tobacco cessation before we move on? All right, if anybody thinks of anything, you can certainly bring it up at the end. Will there be an option to add vaping in? Yes, there is going to be a smokeless tobacco option if there is not already, correct?
Vaping is included. In addition to that, we have had some feedback in the past week from some of our pediatric colleagues that they would like to include secondhand smoke exposure. So the work group is looking at that. This is the Active Solution Health work group. Will continue to meet and again share any additional information. So feedback that you have about the process and the way that it's working is also important, because that's how we improve things as we move forward.
Excellent. Thank you, Rebecca. And Jared just brought this up on the screen so that people can see that vaping is included there, as well as various other forms of tobacco.
And one other thing to mention too is that in the standard work that's going out, there's also instructions to include the patient's smoking status in your schedule view. So if you'd like to have that option so that when you're getting ready to room the patient, you can see whether we've even asked, because one of the statuses it will show you is if we've never asked them, it'll show up there too. So you can kind of mentally prepare for what you're going to be doing in the room. So that's all included in that documentation as well.
Excellent. All right, so with that, our next topic is, I'm not going to reshare my screen because our next topic is a little talk about the Galen legacy system. So Lisa Stemska has joined us to assist with walking us through that.
Hi, everyone. Do you hear me okay?
Yes, we can hear you.
Great. And I'm going to go ahead and share my screen. It'll bring me to Epic, so let me know when you have that.
Yes, we can see Epic.
Great. Okay. So as you all know, not everything came over from Centricity data into Epic. We had about 3 years of office visits. We've had some lab data and radiology data from Saurian, and we had basically all the patient demographics and so forth, and little bits of data here and there. We've had the process of manual abstraction going on and is still going on. We still have Centricity as a read-only version that we are able to still log into and will be able to log in until the end of this year. So 12/31 is what Centricity will remain open for users to go in and look at the legacy data and also do the manual abstraction from, because it is much easier to do the abstraction from Centricity than it is from Galen. We had moved over the last 3 years of attachments from Centricity into Epic. And not sure if everyone knows this, but on chart review, on the encounters tab, we have this document viewer, which is on-base document viewer. If you click that, it brings you to the on-base patient window, and you will see these, they call them tabs on the left, to see certain things here and there in certain categories. Anything that is scanned in today through Index Logic also goes through this on-base patient window. So it's a different view that you could change back and forth to find what you're looking for. So if you know that you are looking for an attachment that is over the last 3 years, rather than logging into Centricity or going into Galen to find it, you may click on that document viewer and find your document a little more easily. So Galen basically is all of the Centricity data. It's all of it. We don't have any, it's basically not a time frame. It's all of the data that was in Centricity copied into this other system. And we have a link in Epic if in case that patient does have Centricity or Saurian data. So both Saurian and Centricity data live in Galen. We have a link here on Storyboard. If you see here on the left, if you click that link, it brings you to a small patient window. If in fact the patient does reside in Saurian or Centricity, you'll be able to it'll jump right to that patient's chart. We have no test patients in the system, so I'm going to actually switch to a presentation to show you screenshots instead, because we didn't want to look at real patient data. When you log into Galen here, it comes in a pretty small window, and you don't really have a full-size screen view button, but you can actually make it bigger by dragging the edges, hovering, clicking, and dragging to make it a little bigger for you to see the data. So now I'm going to hop right into my slideshow. So here we are. So when you first log in, this is the view that you will get, and you'll see a combination. Well, basically it defaults to Cerner, which is Saurian. All of the hospital data, inpatient data is here in this type of a view. If you are looking for just centricity, you would click this group button right here and be able to switch it over to the centricity view. This is the centricity view, and you see tabs on the left: documents, problems, medications, allergies, flow sheets, and orders, and so forth. If you like the old documents view of centricity, one tip to get there would be to you basically stay right here when you're first on the documents tab. You have clinical, diagnostic, and lab. These are like filter buttons at the top. If you click twice on the date, it will sort this list to the most recent on top. So which I've done here. So you're on documents, clinical, you click twice on the date and it put it in the order of sequence here. On the clinical tab, you have office visits, office visit specialists, you have other, clinical documents. Communications tab, you have things like phone notes and letters and other correspondence. The diagnostic tab would have x-rays and other testing. We have a lab tab, which is pretty self-explanatory. And pay no attention to the filed in error or other. We did have to bring them over because we cannot get rid of documents that are filed in error, but they're there if you need them, but you shouldn't have to go there. And there's really nothing on the other tab. If in fact you want to sort your view, you could other ways too. You could sort by the owner, which is typically the provider, or you could use the filter document search or area over here. And if you type in a provider, if you're looking for a certain provider note, if you type that in there, you'll be able to filter your view to only those documents that contain that provider. And here's a view of the diagnostic tab. You would first click twice on the date to see the most recent, or again, you could filter your document to how you want to see it. If you double click on any of those documents, it opens up to the copy of the visit or the lab result or whatever. So basically we have taken a copy of the document and stored it here now in Galen. And so you'll be viewing attachments. You can open it up to a bigger size. And you can also, if you need to print the document, you can also click this export button, which I'll show you a couple of screenshots later. Next up is the problems tab. What would be very helpful for this one is if you were looking for certain assessments that were linked to certain problems, you have them listed at the top and you would just click the link and it would bring you to the office visit that problem was addressed. Medications, it doesn't have that type of linking to the visit, but it does give you a listing of all of the prescriptions that were done on that medication and some more history about the instructions and so forth. And basically allergies is the same way. I'm going to skip down to the flow sheets. The flow sheet is a little difficult. Basically, we took our most common flow sheets and centricity. If you click on the viewing, you can select none and then select only one if you want to view a certain grouping of data that was stored to the flow sheet. So again, if there are certain labs that were outside labs, they would have had to be manually entered in order to appear on the flow sheet. I am going to look at, well, first of all, I think I had a view here of the flow sheet. When you open a flow sheet, you have these newer and older screening buttons that will bring you through all of the dates that possibly was addressed, that whether it be the assessment or the blood pressure or whatever it is that you're looking for. Your view of the items will change as you flip through the dates. So as you can see, smoking status is not here on this one, but if you click the older button over here, brings you to a different view of dates, you'll see it there. So I completely understand this one is a little bit more difficult, especially if you're looking at immunizations. You can't get a full grouping of the immunization record from here without going back and forth to the older and newer. You can, however, search the full chart by going up to the very top toolbar and clicking on this records button, and you can type in a vaccine or a lab or something that you want to narrow it down and filter it out. It will give you all the documents that are associated with that. And you can open the attachment if it's a visit, or you can view on the chart. This will bring up any documents in either Centricity or Saurian. And they'll all be listed at the bottom. You'll have to scroll. Once you do open up an attachment, you do have the opportunity to print it and then maybe scan it into Epic if you need to. You click the export button and then click the export document. You can export the whole chart, which it would take some time and it would be a pretty large document, but typically we're just exporting the document. And it brings you to export chart. It goes through a process of downloading, and then you'll have a button that says open. It also downloads a patient summary at the same time, but your document will be found in the zipped up folder. And as you have to click a couple times and you get there, you open up the document and the print icon is there for you to use. And I guess that's it. Does anybody have any questions? I don't know, Corey, I'm not really looking at I can't see the screen, so.
Yeah, no problem. I'm watching the chat if there's anybody that wants to put a question in there. You all are certainly welcome to come off mute and ask questions that way as well.
Yeah. And again, Centricity will remain available until the end of this year because I know we do have still quite a bit of abstracting to do. And we completely understand it. And we may or may not be able to extend that depending on how far along we are in the abstracting process.
So Jen has a question, Lisa. Is there a list of documents that are already loaded to the Epic chart that we don't have to look for?
Sure. I do have that actually. Let me see if I can just go ahead and end my slideshow here and bring that up. So we have Centricity EMR documents. We have the last 5 years of vitals. We have all the CCDAs, which you have to manually reconcile. The labs come from Saurian Clinicals, and we have the last 3 years. Imaging, we're the last 5 years. Any mid-mark, we have the last office visits and office visit specialists, the last 3 years of those. And we're manually abstracting the colon cancer screening, pap smear, and mammogram, along with a couple of diabetic exams. Advanced directives would be along with all of the Index Logic and DocuTrack scanned documents, which again can be found on the document viewer on base patient window. And those are the last 3 years.
Excellent. Thank you, Lisa. Jen, does that answer the second part of your question? Also, did this include Saurian Clinicals for Cerner?
Yes.
Perfect. Thank you, Lisa. So if you don't mind, Lisa, just sharing, I have that document from you that I can share with everyone who's on the call. And then I don't know if this list would be helpful to people, if we could share that as well.
Certainly.
Awesome.
Certainly.
And I will send that out to everybody when I send the slides out to all of our clinical staff.
Sounds great.
Awesome. Thank you very much. All right, everybody. So moving right along. You should be able to see my presentation again if somebody can just nod and confirm.
Yep, we can see it.
Thanks, Lisa. All right, so a couple of division updates. So I just wanted to remind everybody of the referral bonus program for FMP. We do have some vacant clinical staff positions and administrative staff positions across the foundation, and we do still have our referral bonus program. So if anybody knows of anybody that you want to send along, there is some specific information that you would need, and you would need to be in contact with Doreen Mealy in HR. There are also some stipulations. It couldn't be somebody coming from the Elliott or somebody who has left a Solution Health entity and is now coming back. But it is a good program with some money on the table for you all to recruit some of your friends to come work with us. And then Jared is going to give us an update on the Ambulatory Nursing Practice Council.
Yeah, thanks, Corey. So as we discussed at our first town hall meeting, we were planning to launch an Ambulatory Nursing Practice Council, and we have officially launched. We had our first meeting on May 21st. We've had great enthusiasm and participation from all of you. We had 21 members from 9 different divisions participating. So 12 of them are registered nurses. We have 3 LPNs, 6 medical assistants, and 1 nurse practitioner who have joined. We did adopt a charter and bylaws, which basically just are documents that establish what we do as a group and some of the rules for how we run our meetings and make decisions as a group. So something you all should know is that we also have a pulse page. And if Corey, if you let me just share my screen real quick, I can show people where that is.
Sure.
And I will. So if you are on the Pulse, it's pretty easy to get to. It is under Workplace, and you're going to find committees and councils. And because ambulatory is very high in the alphabet, it's going to be right as the first option for you, Ambulatory Nursing Practice Council. There's not a whole lot there, but it does outline our group responsibilities, and you have a link to look at our meeting minutes here, and you can even read the charter if you'd like. It's really dry and boring, but if you like that kind of stuff, feel free to read it. So what's great about the Ambulatory Nursing Practice Council is we've had the opportunity to get people involved. We will be meeting on a more regular basis. Our next meeting will be July 7th, and we are going to be setting up liaisons between the Hospital Nurse Practice Council and the Ambulatory Nursing Practice Council. So as of right now, I am serving as the chair of the council for the time being, and I'm going to be sitting on the Nurse Practice Council in the hospital. And we have we're bringing Laura Forgione, who's, I don't know exactly what her role in the Nurse Practice Council is. She's not the chair, but she's going to be sitting on the Ambulatory Practice Council as a liaison to make sure that we're working together across both inpatient nursing and ambulatory nursing. And eventually, in some time as we get things established, we will have a member chair of the Ambulatory Nursing Practice Council, and I'll kind of step back out of the way because the goal really here for this is to get frontline staff engaged, and it's your council, not our council, and that's really the goal there. So just an update on that. We're excited about it, and we're looking forward to future meetings and the great work that's going to be done through them. So.
Excellent. Thank you, Jared. Next is just wanted to call out some employee recognition. For those that do not know, we gave the Daisy Award last week to Megan Burnap, who is an RN in the pediatric inpatient unit, as well as a per diem RN in Foundation Peds. She originally was in Foundation Peds and then has gone over to the inpatient unit to expand her pediatric skill set. She was recognized for her dedication to patients, her drive to go above and beyond, and to provide the best possible patient experience, as well as her willingness to help colleagues in any way that she can. A great example of the nurses that we have working here at Southern, and it was a good day to honor her for sure. And she was a good sport. She was coming to celebrate with us after 3 night shifts in a row. So it was a good time. Additional employee recognition. I saw this on our social media page about some of our immediate care nurses in Hudson. So it's somebody who's been bringing their 3 kids over the past 6 weeks for one thing or another to immediate care in Hudson, and found the experience pleasant and accommodating for all 3 of her kids. She really appreciated the nurses, Julie, Courtney, Jen, and Diana, for their expert nursing experience. And the staff at immediate care in Hudson is amazing. Thank you for helping my family. Another great example of the care that you all give every day in your practices. So on that note, if there's anybody that you would like to recognize, we do have a nomination form up on the Pulse as well to nominate someone for the Daisy Award or the High Five Shine. We'd love to see some nominations to recognize some of our great medical assistants, as well as additional nominations for nursing for the Daisy Award. So please, if there's anything going on that you feel like we should know about, send us an email, do a nomination, whatever you would like to do to get us those stories. We want to be celebrating and recognizing all the great work that you guys are doing every day. With that, we will open it up for questions and general open discussion if anybody has anything that they'd like to bring up in the last couple of minutes. And I do have a closing poll as well that I'm going to put on the screen before we end.
Can I speak up here for you, Corey?
Of course.
This is Cheryl, Cheryl Gagne. And I wanted to take a few minutes to say that, I don't know if anybody knows, but Corey's been barely here for 3 months. And I think it's already obvious he's made a big difference in the practice environments, right? And I think he and Jared are working together great as a team. I wanted to just say thank you. I wanted to also say it looks really great, the work that you're doing around getting the practice councils going and aiming for a whole organization recognition going forward for from the magnet program. So everybody, if you don't know, we just had a redesignation for our 4th time. And in order to participate the next time, because of the way the organizational structure has changed, we need to engage the practices and all of the same work that the staff in the medical center are doing. And the importance of magnet, I think that people have to really be appreciative of, is the fact that the real focus of the program is to see practice advancements, to see how nurses contribute to professional improvements, and to recognize nurses' contributions to healthcare. So to that end, I mean, I will put it to you as a challenge. You know, some of the things that we do, we have shared at conferences across the country. Several staff nurses here have presented, and I can see staff nurses in the practices presenting in the future. It's all up to us. To clarify, Laura Forgione is a director over here, and she is the leadership liaison to the practice council. So it sounds like she is going to be the leadership liaison to the ambulatory practice council as well. So if anybody has any specific questions for me, I'm happy to take them.
Thank you, Cheryl. Again, everybody feel free to come off mute or put something in the chat. I think I saw Lisa McCusker on here as well. Lisa, I don't know if you're still on, but I did just want to take a minute to welcome Lisa. Lisa's been here for the last 6 weeks now. And for those that have not met her yet, she is our new Vice President of Ambulatory Operations. So she's working with your respective directors and ABPs and practice managers. And we have been partnering very close with nursing and operations to make sure that we are moving things forward and have things set up to provide the best care possible for our patients and to take care of you all.
Corey, I'm here. I just don't know if anybody can hear me. I have terrible time with my speakers, but I just wanted to say thank you so much to Corey and Corey's team. You know, Corey has been, I've been here all of 6 weeks, and Corey has really partnered in the practices with me and my staff to see what we can do about clinical staffing and then shoring up the operations and the policies and procedures. And Cheryl's been phenomenal as well. And I really am looking forward to a very strong clinical presence in the foundation for the practices and partnering as a collaborative team. So I just want to say I'm looking forward to meeting each and every single one of you, but Corey and I are going to be a well-knit team, as well as other operational folks as Rebecca and others, but certainly looking for that clinical presence and clinical expertise from Corey and his team. So Corey, I just want to shout out to you. I couldn't thank you enough for everything that you've done in the last couple of weeks with me. So I'm looking forward to more. Thank you.
Thank you. And to all the clinical staff that are on the call, I promise I didn't pay anybody to give me all of these accolades at the end of the meeting, but I do appreciate it. So with that, I am going to open up a poll for everybody. Just give me 1 second to just get some real-time feedback on how helpful we thought this was and what we'd like to see in the future. So if you can take a few minutes to answer those 3 questions, that would be great. Leave it open for just a few more seconds. All right. So everybody should be able to see the results on their screen. Looks like 77% strongly agree that this was helpful and 23% agree, so that's good. I'm happy to see that. I'd like to see town hall offered once a month with 73% of the time, and every other month 27% of the time. So that's good. That's what we're targeting as well. So just so everybody knows, this was about 6 weeks between our first town hall and today. And then I threw a question in there about communication in general. So looks like most people are happy with emails as needed. This was a select all that apply. A bi-weekly newsletter, a monthly newsletter, huddles in the practice, and the pulse. So kind of a mixed bag, but looks like emails working for people. And we will be looking to stand up some sort of newsletter. And we'll figure out the cadence on that, but it does look like we had a good chunk of people that feel like they would benefit from a newsletter. We are still figuring out how the logistics of huddles and the practices would go, and we will keep, Jared's been doing a great job with our all of our materials on the pulse to make sure that they're up to date and easy to use. So with that, I think we will close it out. Thank you to those who have made some comments in the chat. There is one last question. Will staff receive a notification when the recording is available? Yes, and I will email out the recording of this session, the slides, and the resources that Lisa presented to all the clinical staff, and then we will post it on the Pulse as well. All righty. I hope that everybody has a great weekend.